I'm going to hit the record per Sasha's request. And then we're going to start out with a video about our program.
Caleb, why be a Christi?
That's a good question.
Note the time. This delivery was my 14th C-section as the primary surgeon, and then about my 151st delivery overall. And I've still got a year of training left to go.
I have grown to really love clinic because we're able to just be there and to love our patients and to pray with them.
Coming from like a big city, I really knew the full scope of family medicine until I got here.
I am driven by my faith to do overseas medicine. This program just happened to also have a lot of like-minded people who wanted to serve and also get great broad training.
What really made a difference to me when I was interviewing is the people here, the way people were drawn together to each other, supported each other through the journey of residency.
There have been some ups and downs, but you know, one thing I've noticed is that there's always somebody to pick you up.
And I remember one time I was on back-to-back service and one of my seniors, he was like, "You're checking your pager out to me today. You're gonna have the afternoon where you can just focus on family and health and wellness."
It really just feels like a big family.
Our spouses don't feel left out of anything.
When we came to be Christi, remembered this was it. This is the culture. Like you could feel the okay, I've got a vision beyond medicine. I'm not just treating patients. Yeah.
Came back here from Florida, not to Wichita, not to even the Christi program, but to the people that are in it.
Just getting it out of.
We work really hard. We work long hours, but I work with my best friends. And then when we get off, we still want to hang out with each other.
Yep. Looking for a family environment and a program that would reinforce the work-life balance that I'm looking to build as I build a practice.
I'm gonna drop you down just a little bit.
Okay, see it. You just kind of find this moment where you know it clicks.
I think I'm healthier and happier than I probably ever have been in my life, which is really saying something after coming off your first year of residency.
There are a lot of residency programs out there, but one of the things that I loved about Via Christi was that I didn't just feel like I was going to get a good education and that the work-life balance was going to be good, but I felt like I was going to be challenged and the work-life balance was going to be great.
Oh, good. Yeah.
All right, well, welcome. I think we had a few more people join us while the video was playing. My name is Philip Dooley. I'm the program director here at Via Christi. And we just have a couple of quick slides to run through, and then we'll plan to open it up for any questions you might have. So our mission at Via Christi Family Medicine is to teach comprehensive family medicine to residents of character who are called to serve their community with an emphasis on patient-centered care. So how do we go about doing that? We are a community-based program academically affiliated with KU Wichita. And we're really focused on preparing residents to go wherever they may choose to go, and that really when you come here, you're not closing any doors on your future practice. So we have 18 residents per class, we have 2 hospitals, and that gives us an opportunity to provide training in a community hospital setting to help prepare people for rural as well as a tertiary care center, and all of the benefits that has. As the videos showed, we do have international fellowship, a sports medicine fellowship, and we have osteopathic recognition. Our residents come from all over the country. This map isn't proportional because at least a third or more of our residents are coming to us or staying with us in Kansas every year. But we do have residents currently from 25 states plus Puerto Rico, representing 28 different medical schools just in the current class. And then this is just showing you what our graduates from the last few classes have done after they've left. So you can see a half or more are engaged in various types of full scope family medicine, doing outpatient, inpatient, and OB. But you have a lot of people doing all of the other options that are open to family physicians. It's one of the great things about family medicine is we really are kind of the pluripotent stem cells. Even at the end of residency, we can still do a lot of different things. About half of our grads, actually exactly half of our grads over the last 5 years are going to rural practices, which is 9 per year going to rural practices, even though we're in an urban location. So in absolute number terms, that has us putting more people into rural practice than any other program in the country, at least at the Rural Training Track Collaborative has data on. I'm going to turn over to another one of our faculty member, Dr. Stringfield.
Welcome, welcome. I'm kind of the old guy here.
How do you tell if it's lagging?
What's that? Let me hit these slides and then we'll kind of open up the conversation. Basically, one of the things that we find that the students are particularly interested in is how we care for the marginalized people. Our clinics really serve the underserved of Wichita. It's not unique for other programs, it's common, but just so you have an idea that coming here, you'll be involved in the care of people who are underserved. There's several clinics we work out of. You can see our percentage population of the payer source as far as Medicaid, uninsured, charity care, Medicare. You can see it's kind of a split below in terms of diversity that we see as far as patients. 41% non-Hispanic white, 27% African-American, 24% Hispanic or Latino. We just started something relatively new. It's medication-assisted therapy for buprenorphine for opioid use disorder, which is something that's we think is important, and obviously we're excited about that particular thing. Our inpatient population, basically, the teams we care for EMTALA sort of practices where we're taking care of the unassigned plus our own large patient base. We have almost 70 physicians within the residency. We care for those patients, which are our personal patients, when they get hospitalized or when they deliver. But then we care for unassigned patients at both hospitals to include adult medicine, pediatrics, and OB newborn. So we even have higher rates of caring for patients with no insurance or primary care. Next slide, Philip. I think one of the things that I like to say to students is it's easy to look at programs and think this is kind of a job interview and what are you looking for? And kind of trying to present yourself for that program. But I think it's important that you look at each individual program tonight and in general in the interview season and try to figure out what they are seeking. And so if you ask that question, which I recommend you do, because then you'll know if you fit, is we're really pursuing a trajectory that produces truly full spectrum rural, strong OB training, inpatient ICU, kind of with a heart to serve, whether that's rural, underserved, urban underserved, global interested sort of students. And I think one of the things we would say is people who come to our program want to fit the philosophy, the residency culture, and the community of the program. And that's something you have to kind of discover, which will be challenging this year virtually, but you still can do that as you get to know the people who are here or at any program as you look at that. We're really looking for people with the right character traits, because we've seen that if we find the character traits of an individual, we generally know what they're going to be like when they're here. And so we're looking for physicians who are going to be hardworking, teachable, compassionate, humble, and interested in leading, because that's what we really do, and interested in teaching as well. We also emphasize something about kind of an emotional quotient. People who are self-aware, they're sensitive to others. Obviously, you can see in this day and age, that's something that's ignored by many people, but we really want to be paying attention to what other people think, what other people feel, what other people, their opinions that they have, especially as they affect them in terms of their lives and their health care. But we want to be doctors who are willing to listen and respond and willing to serve. I think that's it, Philip. Yeah. So we're going to throw it open for questions and then just kind of take a stab at the questions if you have them. Thoughts, questions from the gang?
I have a question, Elizabeth.
Sure.
Are you guys able to hear me? Great. Okay. I was just curious, with everything going on with COVID, what kind of changes do you guys see happening to the international fellowship aspect of your residency in the next few years?
Philip, you want to take a stab at it? Or you want me to?
So the international fellowship is run through Via Christi. It's not a ACGM accredited fellowship, so it's not subject to the KU travel restrictions. So as far as we know, if the countries they're planning to go to will have them, they're still going to be going and doing it. That's obviously all subject to airlines not having flights there, or countries imposing travel regulations on people coming from the US if our cases remain where they're at. But it's not as shut down as international rotations through KU.
Yeah, definitely. I would say that. I mean, our last fellow was somewhat stranded in Bangladesh, and he ended up becoming the primary COVID officer for a large hospital and a large population. And they were very grateful to have him, and he learned a lot from it. I think, as is anything, when you travel internationally or when you're working with other countries, things change in a heartbeat. So it would just depend from year to year. That would be something that's a few years down the road for you, Elizabeth.
Thank you.
Other questions?
I have a question.
Go ahead, Vanessa.
Hi. So I was curious, how has your residency program changed since COVID started, and what services have you provided to your community that are in need since COVID?
Philip, I'm going to let you take a stab at that. I couldn't quite hear it.
I was going to let Matt.
All right.
Thanks. Hey guys, Matt Trax. I'm one of the PGY 3s in the program. So changes to our program since COVID started. The ACGME, so the governing body, opened up more like tele and video visits. And so our clinic has implemented that, which is a great new skill to have, because obviously all the private, or like once you get out, you're going to be doing that right now anyway. And it's just been a different way to learn and a different way to run clinic. On the inpatient side, we continue to take care of our patients, including if they have COVID. And so we're obviously working closely with the intensivists, but we are taking care of them, and we are learning how to manage it, what the presentation is, and dealing with all the complications from it. On the OB side, we now wear face masks for deliveries. That's like the everyday, day-to-day problem or issue. But we had to come up with our contingency plan. So one of the great things about our program is we're the only residents in the hospital where we deliver babies. And so there's no OB-GYN residents. We are the ones doing all of the deliveries, everything. So we were the ones who were figuring out how to deliver these babies safely, and how to deal with positive, COVID positive mothers and all of those kind of things. So from a program aspect, it's impacted us every step of the way, or every part of it. But, you know, I think our program is stronger for it, and we've gotten to do a lot of learning. As far as reaching out to the community, a group of us put together these like COVID care packages for our patients that we've been giving out, including masks and some hand sanitizer and things like that. And then just in general, reaching out to our community as a whole. So we are like a very high % Medicaid and non-insured population. So just everyone who walks into our door, we are reaching out to the community and helping those who need help, providing them masks, things like that. And then you have the opportunity to work at Guadalupe Clinic, and so that's a no insurance place as well. So that's another opportunity where we have to reach out to different members of the community.
Thank you for answering my question.
I have a couple questions.
Go ahead, Tyler.
First of all, I wanted to kind of ask about what's the call like for the residents, you know, first, second year, third year. And then I also want to ask kind of like how many procedures, colonoscopy, EGDs, the typical resident could see, or kind of how that's going as part of the full spectrum kind of thing I'm interested in.
Jared, you want to take a stab at that?
Yeah, sure. So to address the first one with the call schedule, that kind of varies a little bit based on what rotation we're on. And sorry, yeah, I'm Jared here. I'm one of the third year residents along with Matt and Whitney here. Yeah, so first off, like for example, I'm on inpatient medicine right now. So we kind of alternate. Currently this week I was on rounding. So I'm rounding in the morning, either doing admissions or in clinic in the afternoon then. So I'll be on call basically from 6 in the morning until 8 o'clock at night. We just changed recently. We used to take inpatient call 24/7 basically for the whole month while we were on inpatient, but we no longer do that. And that I think has been a major change.
You're not in the hospital until 8 p.m. I just want to make that one clear.
Oh, sure, yes, sorry.
You are available by pager, but you actually get relieved by the night team at about 5.
Yeah, but usually we take our own pages until about 8 p.m. So yeah, sorry, I didn't clarify that. And then overnight, then there is a night team for medicine, but there's a both a first-year resident and then either a second or third-year resident on that team that is doing admissions and then responding to pages for our family medicine team overnight. Somewhat similar situation on OB, except for that you're basically either on for nights or for days, and you're just like taking calls while you're there. And once again, that just is basically from 5:45 a.m. to 5 p.m. and then vice versa for nights, obviously, as well. Peds, once again, similar schedule for calls. So we do for nights, we do 1 week at a time on nights. When you are on one of those core inpatient rotations, with those being inpatient medicine, inpatient peds, or inpatient OB. So it ends up being you do 7 weeks of nights total during your first year, 6 your second year, and then 5 your third year on average. There's a little bit of give and take with that, but that's the average of that. And then usually when you are not on one of those inpatient core rotations, there is on average about 2 weekend shifts per month that you cover during your first and second year to help give those that are on those inpatient core rotations a break during those months when they are on. So does that help answer some of those questions? Any specifics I forgot, anybody?
The weekend shifts are like a roughly 12-hour shift. You're not like covering the whole weekend, and we don't have 24-hour call shifts. It's only the call on the days you're scheduled to be in the hospital.
On PED second year, you have 1 24-hour call shift. So you get the experience of having done one, but it's typically our least busy service. So.
And Tyler, I tried to answer your endoscopy question in the chat.
Thanks. That was a lot more detail than I was expecting.
It's okay. I have a quick question. So I'm student Dr. Wes Goodrich, and I was curious, this is actually a question, I guess, for some of the residents. What resources have you found most helpful and beneficial kind of throughout the duration of your residency?
Up to date. Up to date. I mean, you guys probably already know all about it, but it is a lifesaver. I'll let other people talk. MD Calc is also one of my favorites. So that's, I mean, these are all probably ones that most of you have. If anyone else wants to jump in while I pull up my app folder.
A lot of people use, I'm Erica, I'm one of the second year residents. People also use Dynamed as like an equivalent to Up to Date. People use Hippocrates for drug references. And then I know I personally will look things up on the AFP website and find articles because they provide really good summaries a lot of times. And also I have some different articles I've collected from throughout my rotations, either from ACOG or the AAP that I can reference, or, you know, a lot of notes from specialists, or our didactics can be some really good resources if you take good notes.
And
Just
I would
to follow
piggyback on what,
I'm sorry.
I was going to kind of piggyback on what Erica said. Something that Dr. Stringfield taught us, like at orientation our first year, was just having some sort of system to collect electronic notes. So most of us use either Evernote or OneNote. And so I have, I don't know, 150 topics of notes that I've taken from specialists while I'm on rotation. And so I come back to my Evernote. I mean, I have it open on my tab 24/7 because I'm always looking stuff up on there. And that honestly is probably one of my most used resources, because you just get like so much information on those different rotations. And if you don't like have a systematic way to utilize it, then it becomes a whole lot less useful. So, yeah.
And one little piece of free advice, if you can consolidate your notes from third and fourth year rotations before you start residency, that's going to be really helpful to you, because you do learn a lot of really useful information those 2 years. And I went and consolidated my notes about 7-8 months into residency because I was so frustrated that I could never find them. And then I knew they were there and they were useful. So that's also a good resource that you can still rely on. You don't have to keep finding new resources. You can go back to stuff you've already learned.
I'll jump in. I have two things. Journal Watch is really good. It's a summary of the literature. comes out every 2 weeks. It kind of gives you the top 50 journals related to primary care. It's particularly helpful. It's nice for someone like me who's ADD. It kind of gives me the summary of what they concluded, whether it's useful or not, whether it's helpful, whether it's legitimate research. The other thing I rely upon is Dr. Dooley, because he knows all the answers. So.
And I was going to say my seniors, that is my favorite resource right now. So I go to my seniors for everything, and they type a lot of the notes too, and they kind of present it. They teach all the time, so I think that's really helpful to kind of keep track of the material. And also our didactics are really helpful because we have our faculty, our residents, and our specialists come in and teach very, very practical things that we see on a daily. So those are my two favorite resources right now.
Hi, my name is Tejal Shalad. I'm an international applicant. I just wanted to ask if you guys accept international applicants, and I have graduated more than 3 years back. Would you consider interviewing someone who's graduated some time back and is interested in your program? I'm especially interested because of the international, the preparation for international health.
Philip, you want me to take that? Sure. Well, generally what we did is we set up some criteria. The fact that you're more than a year out of graduation, usually what we found is that we have used that as a screening criteria because it's been very challenging for students, or graduates, I should say, to come into our program and hit the ground running. Years ago, that was something that wasn't a screening criteria, but now it is. And so it's unlikely that we'll change that because of the huge volume of applicants that we have, Tejal. That my apologies to that, but what we found is that it's just really a struggle because our programs are busy and, or I'm sorry, our core services are busy and active. And if you haven't had hands-on patient care, particularly obstetrics, it's really going to be a struggle.
I understand. Thank you.
You bet. Anybody out there scared about the virtual season? It's a challenging year for all of us.
Can I ask another question? So I'm curious, you guys talked about how emotional intelligence and things like that are important to your program. How do you plan on gauging that in this virtual environment?
Good question. You know, emotional quotient is the ability to read the room. It's the ability to kind of consider the people you're with and act appropriate. It's not doing things that make people uncomfortable. It's being aware of how others in the room might think of things that are different than you or look at life different than you. I think it is challenging to pick that up, whether it's a virtual or non-virtual live face-to-face environment. What we use for the criteria is how you come across in an interview. Now, Elizabeth, you're going to do a rotation with us, so hopefully we'll discover that. But the other way you pick it up is the MSPE, your dean's letter, basically the comments that are made from that. Oftentimes people will comment about things that we kind of key into that are important, like they're hardworking or they're really teachable or they're very compassionate. Those are the kind of things that we're looking for in terms of character qualities that tend to go along with that. But you are correct, Elizabeth. It is a hard thing to sometimes determine. The other thing we rely upon, letters of recommendation, oftentimes many will help us with that and will give us an indication of how well, or perhaps not how well, an individual student would do in that area. Anybody else feel free to take a stab at it?
I don't know that this is EQ, but so far you are all crushing the don't do this from a coffee shop or of their crowded place. We've had them before. It's not great. Yes. So like be cognizant of what is your background and what is your environment when you're interviewing, because if you don't have the, like, you can't think ahead to that, then that's a red flag to me. Vanessa, I like the color scheme of yours. You guys don't feel the need to put a minion in. I'm currently in our pediatrician's office, so that's why my background is like crazy busy. But like, if you casually like have something fun in your background, that's a good interview something, since we're not going to be able to ask you, I don't know, it's just going to be different. And so being cognizant of what your surroundings and background is one way that, like, it probably can't help you that much, but it definitely can hurt you.
Others?
Yeah, I would venture to guess that will probably be the biggest challenge of the interview season, on both ends. I mean, both for students and for residency programs, because as Dr. Stringfield said, that's probably like, I mean, the being teachable and coachable and just getting along well with others are like three of the most important things that I think we would look for in an applicant. And then hopefully you want to be surrounded by other folks that are like that. And so, and like both Matt and Dr. Stringfield have said, it's kind of hard to get that on Zoom. So being creative and finding other ways to communicate that to programs, I think would be important.
So I had a question here. Can everybody hear me? Yep. So I was just curious if anybody in your program had any experience with public health, and if there were any opportunities with either activities that you guys have or just opportunities that residents set up to either do public health projects or participate in like advocacy or research. What kind of things that you guys have for opportunities in that way?
Philip, you want to take a stab at that?
I'm happy to let a resident go unless if they all want me to take that one.
I feel like you can talk the logistics first, and then one of us can jump in on just like our experience, because to be honest with you, I haven't done public health projects, so I'm going to let him take that part.
Yeah, we work very closely with, we have 2 PhDs, one of whom is funded, if you're from the Wichita campus, Samuel Ofe-Dodu is funded by our program, but intentionally stationed over there at the medical school campus so that we can coordinate on research projects and endeavors, whether it's with the public health department, whether it's with pediatrics, internal medicine, whether that's with Wesley, Salina, whoever it is, they're intentionally over there to help coordinate those kinds of efforts so that if they know you have an interest in something, they actually meet with you during orientation so that they find out what you're interested in. And then when those opportunities come available, they'll connect you and plug you in. But just there's also free clinics that you work with, rotate through. Obviously, we encourage residents to help supervise at JDoc and keep working with the students there. And that's certainly meeting a need in the community. And then what was the other thing I was going to think of? It'll come back to me at some point.
And that's right. What was their name? What was this PhD thing?
Dr. Samuel Ofe-Dodu. He works in the Family and Community Medicine Department at KU.
I'll copy paste into the chat so you don't have to try and write that.
Awesome, thank you. I was going to ask for a spelling.
Yeah, and just on a personal note, I would add, like, he makes things, like, he's so incredibly helpful, such a good resource to be able to do. I mean, he's so talented in many different ways and so well connected to be able to basically help you get to whoever you need to talk to. I mean, like, just the other day, another resident and I, we were writing up a case study, and then so he emailed somebody he knew from the Cleveland Clinic to get some pictures from their journal in Lancet that we could use to help better show our like what was going on in our clinical scenario. So like, just that's one teeny little tidbit, but that's kind of an example of how helpful he can be.
And it looks like they're going to move us quick, but it's escaping me now. I did it probably 2 years ago. There's a rotation that we have that's a outpatient rotation that we're able to spend at least a half day with public health and kind of like in Sedgwick County and see what they do and how they operate. So there is that experience too.
Awesome. Thank you so much.
I think you got that in just in time before he got yanked out. All right, thanks everybody that's still here, not from our program. Great to see you.
It's the final countdown. Do-do-do-do. Do-do-do-do-do. Do-do-do-do.
So I think that one ended up being longer because I think we got started before they expected us to start.
How long are they supposed to be?
20 minutes.
20 minutes, yeah.
Is this like an event where we're trying to get them? Like, should we go around and say, like, I don't know, 20 seconds of why we ended up at Via Christi to start off with, or something? I don't know if that was effective or not.
That's a great idea, Matt. Why don't we do that after we present? We'll kind of throw it up and then see what they say. So each of you will just go around the room. Matt, you start us off, okay?
Great. I want to know what Winnie and Jared are laughing about, though. I want to know what you guys are laughing so hard about.
Our text.
You know, it's interesting. We sit here and talk about EQ, but we sit here staring at our screen. Everybody's just staring at the screen and nobody's saying anything. It's an interesting time we're in.
Yeah.
Poor Elliot, like, turned on his camera 3 different times trying to say something. And then he would get interrupted and he'd, like, shut it off quick.
Should we make note of that?
I think we'll be able to tell. I mean, I don't feel like the interviews will be too different. Like, I was surprised interviewing last year how much I could tell about someone's personality and their emotional intelligence just from a conversation with them and not actually working with them. So,
I mean, when you think about it, what we're really talking about is maturity.
Yeah.
You know, are they ready to handle what it is that residency is all about from what we know? Or do we sense that they're unrealistic or ill-prepared? That's really what it ends up being. I probably should have said something along that line. Speaking of the young lady who asked about applying outside of 2 years,